Hare. And we begin the first talk with cross-linking, when to do, when not to do, how to decide about it. Let's have Colonel Vijay Sharma, who will be talking about cross-linking, when and why.
Thank you, sir. So, should all keratoconic corneas be cross-linked? I'll be covering, at least after the IC, we should be able to answer all these questions. So, it was Volensek et al. In 2003 when they first published about collagen cross-linking while working at Technical University of Dresden, and it came to be known as a commonly a Dresden protocol. So, what happened? What did they do? They saturated the cornea with riboflavin dye, saturating it every 5 minutes for 30 minutes, and after that it was irradiated with 370 nanometer UVA radiations, and this resulted in increase in cross links in the collagen fibrils, and this strengthened the corneal tissue, and also it stopped the further progression of corneal ectasia over next few months after the progression was completely halted. So subsequently the CXL indications, they have extended significantly the ectatic disorders as well as non-ectatic disorders. In ectasias, the keratoconus, the primarily where the collagen cross-linking is done, and it has also been done in pellucid marginal degeneration and post-laser ectasia. In non-ectatic disorders, the infectious keratitis, bullous keratopathy, chemical injuries, TMD, the CXL has been done with varied results which have been published from time to time. In keratoconus, now what are the various options which are available? So if the corneal thickness is more than 400 micron, the isosmolar collagen cross-linking is done. If the corneal thickness is less than 400 but more than 330, then in those cases a hypoosmolar collagen cross-linking is done to prevent damage to the endothelial cells due to the UV radiations. It can be combined with PRK, as in topo-guided removal of epithelium in keratoconus, or a TREC procedure. Can be combined with the PTK, as in Creighton protocol, can be combined with intracorneal ring segments, and also the customized cross-linking, as in photorefractive intrastromal collagen cross-linking. Now, what are the various other aspects in addition to corneal thickness? The age is also important parameter. In adults, normally we document the progression, and whenever the progression is documented, then we can go ahead and perform the collagen cross-linking. In children, documentation may not be required, and in children, especially if there is an earlier onset of keratoconus, there are very high chances of severe progression. So in these cases, the earlier cross-linking is preferred. Also, the possibility of GA should be kept in mind in very young children who cannot undergo under the topical or local anesthesia. Now, how do we, what do we say as a, when do we say that keratoconus is progressive? Now, there are different criteria which have been published from time to time. The most, now since individuals are using the different platforms of sham plug devices, be it a Pentacam or a Galilei or a Cirrus or even OBSCAN individuals are using. So, most preferred definition for keratoconus progression is if there is a progressive steepening of anterior corneal surface and progressive steepening in the posterior corneal surface, or progressive thinning. At least two of these three parameters should be, there should be a consistent change over a period of 6 months. If these changes are present, then we call it as a progressive keratoconus. And what are the protocols which are available? We have a conventional protocol or an accelerated protocol. In the conventional, the Dresden is the standard conventional protocol. It can be done by epi-off or epi-on technique, but epi-off is preferred because epi-off has a better efficacy compared to epi-on. In the epi-on, the patient comfort is better, but the efficacy is much less. One study has found that efficacy of a epi-on technique is just 1/5 of a conventional standard epi-off technique. This is due to the unreliable penetration of riboflavin through the intact epithelium. Now, in the accelerated protocol, which technique to follow, whether 9 milliwatt per centimeter square for 10 minutes, or a 18 for 5, or a 30 for 3. So many studies have been published, and consensus is if you follow a 9 milliwatt per centimeter square for 10 minutes. That provides the benefits of as far as the efficacy is concerned of a conventional protocol, as well as the patient comfort which we want as per the accelerated protocols. So it's a good balance of both, and the efficacy is almost equivalent to the conventional protocol. Now many other things have been tried. Supplemental oxygen, yes, many studies have been done, and logically, because if there is a high irradiance, that may cause a higher oxygen consumption, and if oxygen is supplemented, it will lead to a better efficacy. But very few people are doing the supplemental oxygen CXL as of now. Now continuous or a pulse accelerated collagen cross-linking. Again the same principle. The pulsing of the UV light during the collagen cross-linking procedure that allows reoxygenation during pauses in the exposure, and that leads to better efficacy of the procedure. Iontophoresis, not many people are doing, although it's described non-invasive intact epithelium. There is a better saturation than Epion approach, but the efficacy has been found to be slightly inferior to the conventional protocol. Contraindications, any prior herpetic infections, because you are doing the UV radiations, so that can activate the herpetic infection. Any concurrent ocular infection if present, neurotrophic keratitis, history of poor epithelial wound healing, and severe dry eyes. These are some of the contraindications, and one should be careful while doing the CXL. Now repeat CXL. So many cases you have the failure, and which are the conditions where you will have a CXL failure, especially children who have got allergic conjunctivitis and who have got very high eye rubbing tendency. Those are the children or those are the individuals who are likely to have a CXL failure. Again, if a Kmax value is more than 58 and paracentral cone, they also have been found to be a risk factors for repeat CXL requirement. So just few cases. Now this is one case. In one eye there is a hydrops, and other eye there is a keratoconus. So should we wait for documenting the progression? No, we should go ahead immediately, because other eye already had an adverse events. So no need to document the progression. At the initial evaluation only you can go ahead with the CXL progression. Now this is an op scan which is showing the thinness Pachy around 399. So if you wait for a progression in such a case, the pachymetry value may go below the safer limit over a period of time. So in such cases, again you should go ahead with a collagen cross-linking without waiting for any documentation. Same here, a pentacam showing the thinness Pachy value of 355. If you wait, then again it will go down the safer limit of the corneal thickness. So this is one case now in which the pachymetry are good. It's very early keratoconus. So in this you can wait for a documenting the progression and then plan CXL. Now this is another case, very severe, Kmax value of 76 and 71, and the thinness Pachy of 428 and 376 on Cirrus. So again these cases you should go ahead with the CXL at the earliest. Thank you.
Thank you, Dr. Vijay. So, would you have any form of relaxation with respect to age? Like if the patient is above 35, 40 years of age?
In those cases, we can follow for any progression of keratoconus rather than going for an early CXL, because most likely the keratoconus is going to be stabilized as per the age-related glycemic changes. So in those cases, you can wait for if there is a progression. Otherwise, if it is already borderline or other eye is having adverse event, it's progressive, then you can plan. But otherwise, in a normal cases, you should follow these patients for any progression if for documentation.
Thank you very much. So next we'll have Dr. Rajesh Sinha. We'll be talking about CXL in thin corneas, the role of additive keratoplasty and oxygen supplementation.
Thank you very much. In a thin cornea, what is the biggest issue? We all know that if the cornea is thinner than 400 microns and the UV rays are focused onto the surface, there is risk of damage to the endothelium. So I will be discussing about ways to increase the gap between the UV rays and the back surface of the cornea. So one which is very commonly used is hypoosmolar riboflavin, which is 0.1% riboflavin in 0.9% saline, and that can be used to have a good outcome reasonably good outcome, and studies have shown that it does have an effect, although it is much lesser than conventional cross-linking, but it does have an effect. Then another option is contact lens assisted cross-linking. If you place a contact lens, then that along with the tear film and the contact lens thickness, it will increase the gap, and there you can have a safe endothelium. However, the point is that cross-linking works mostly in anterior two-thirds of the cornea, mainly in the anterior two-thirds of the depth which is treated. So part of it will be covered by the contact lens and the tear film, so that will be discarded. So the effect again will not be that great. Some people have used smile lenticule again over the surface, but again the smile lenticule will later be discarded. So the effect, as we see in anterior two-thirds of the cornea, the effect will be subnormal. And some people, in order to reduce and maintain the thickness, they have done transepithelial CXL in thin corneas, which are, say, as Colonel Vijay was telling, 399, 400. If you keep keep the epithelium, it is safe. But the efficacy has not been that great, as earlier Colonel Vijay was also discussing. The safety, the pain is not there, but it is safe, but the efficacy will not be that great with this. So we planned about 7-8 years back, we started doing the additive keratoplasty. And in corneas wherein the thickness was less than 400 microns, we created an intrastromal pocket with femtosecond laser, and we used a negative meniscus lenticule, and then we did accelerated cross-linking. We call it PHILAC, which has been published in the Indian Journal of Ophthalmology. It is femtosecond laser assisted intrastromal lenticule implantation with accelerated cross-linking. And it has basically, in these cases, we have to see to it that the corneal thickness is up to about 320 microns, I mean not below 320 microns, and the cone size should be less than 6 millimeters. It should not be greater than 6 millimeters. In this, microkeratome is used to prepare a stromal lenticule, and then the central part, we create an 8.5 these days. Earlier when we started doing 7 millimeter lenticule, but now we do 8.5 millimeter lenticule. And then the central part is ablated by 75 microns. So we reduce the central thickness from 200 to 125. The basic idea is that we would like to implant a negative meniscus lenticule so as to create an arc shortening effect, and that is how we can have a reduction in astigmatism. So initially we started with the Visumax system, no financial interest, but with that the largest size of pocket that we could create was 7.8, and the lenticule that we implanted was 7. So we moved on to FS200, and with the FS200 we could create a 9 millimeter pocket. So if you create a 9 millimeter pocket, you can implant an 8.5 millimeter lenticule easily. And after putting riboflavin in the pocket and also soaking the lenticule with riboflavin, this lenticule is inserted inside the pocket, and it is spread all around. And in one subset of patients, we have put suture in this pocket, in this opening of the pocket, and in one subset we have not. And it's an ICMR project we are doing, and we will evaluate the data now in another 3-4 months. Post-operatively, what is important is that you do have 2 interfaces. So the risk of interface haze is very high. So topical steroid should be used for at least 6 months to 1 year, and because the risk of haze is very high. And this is how it looks like on day 1, and then at 6 months. And these are some of the cases which are absolutely clear, but not all cases will be absolutely clear. There can be some interface haze in spite of using topical steroid. If you don't use topical steroid for long term, then the haze will be more. And so we did this procedure and saw the changes in topography. We found out that the astigmatism reduced significantly. Like in this case, it is 53.9 and 59.2. It reduced down to 52 and 53. Similarly, there are some other cases also. A couple of cases they fared badly when the cone size was bigger, and particularly when we had the smaller lenticule, because the thicker part came over the cone. So the idea is that we should take a case wherein the cone size is up to 6 millimeters, use an 8.5 millimeter lenticule so that it does have a good arc shortening effect. This is the result which was published. Now, in spite of using steroid, we found out that some of the cases did have some haze. So we started doing Bowman stromal inlay. We all know that in keratoconus, the Bowman is weak. So if we provide a donor Bowman, that will be useful, and if you add some stroma to the cornea, that will further add to the tectonic strength, and that was the basic idea. So with the Bowman stromal inlay, again, after debriding the epithelium completely, lenticule was created. This lenticule was further, with the help of a Trifine, it was made 8.5, and then the back surface of the Bowman stromal inlay, not the Bowman area, but the stromal area, it was the back surface in the central 4 millimeter, it was ablated with excimer laser so as to create a negative meniscus lenticule. And then this, a pocket was created, 9 millimeters, and then this lenticule was implanted inside. And no cross-linking has been done. And we are doing a comparative study between the Bowman stromal inlay and the Philac, wherein the cross-linking is also done. So this is how it looks like. And initial results are quite gratifying. This is one of the post-op pictures. After comparison, maybe in another 6 months' time, we'll be able to know. Just a couple of slides more. Adaptive fluids has come up, and it was proposed by Farhad Hafezi group, but unfortunately it raises more questions than the answers, because sub 400 protocol, in that even a 240 micron thick cornea, you are using 3 milliwatt per centimeter square for just 2 minutes. I don't know how much will be the efficacy, and plus when we talk about endothelial protection and up 400 microns thickness to protect endothelium, how can we protect the endothelium if we are ablating 240 micron cornea? Then they did not evaluate, in the study they did not evaluate the specular changes. They just told that there was no corneal decompensation. But we know that these are young corneas, and even if after damage of endothelium, significant damage of endothelium, the cornea will not decompensate immediately. So there's a lot of query. Coming to the last thing, that is Theo Salek group did animal study using oxygen supplementation. The idea was this, that with exposure to UV rays, the oxygen saturation goes up. So this is oxygen saturation. This is goggle made by Avedro, which is quite costly. We made an indigenous goggle, and oxygen machine, through which the saturation was measured, and we found out that the oxygen with 5 liter per minute of oxygen supply, and we found out that there was some reduction, greater reduction in Kmax, but it was not such a great change seen with the oxygen. So perhaps we finally concluded that perhaps there are other factors also apart from just the oxygen. And this is another study which we have done in corneas which are about 399, 400, whether we should do a debrided hypoosmolar or we should do a trans-epi. We compared the two groups, and the answer is that hypoosmolar is more effective. Thank you very much.
Thank you, sir. Any question? Yeah, we can take one question. Sir, question for you. Sir.
Not a question rather than a suggestion.
Yeah.
We never thought of taking green light with rose bangle.
I have done 3 cases with rose bangle. We take 4 strips of rose bangle, put it in the distilled water, make a 5 ml, and the same procedure, but green light 520 visible light. And all thin corneas, all 3 of them, one was 350 micron, around that, all 3 of them. And the effectivity was very good. We had a flattening of almost 5 to 6 diopters, because the green light does not penetrate and go up to the endothelium. The only problem is to use the rose bangle. Today we are using off-label for the strips. We do not have any permissions for making an injection for it. We are not able to get that permission because nowhere in the world these injections are made. So we have to start from the beginning. There was an article in which the rabbit eye, the effectivity of rose Bengal with green light is 11 times more than the CXL with riboflavin. I think all of us must consider the green light, and it's very easy to make because it's a visible light.
I've gone through that article, sir, and I completely agree that they have shown. So you can keep it there. They have shown very good results with this, but we haven't done a study, so we are not in a position.
We had done about 6 cases. 3 of them is by me, and 3 of them is by Dr. Kakadia. It's a fantastic. Only thing is the haze is little more than what it should have been.
Wonderful. Okay, next I would like to invite Dr. Swapna Nair. She will be speaking about intracorneal ring segments, when to do in keratoconus and when to combine with simultaneous or sequential CXL.
So we'll just go into the role of intracorneal ring segments with or without CXL in keratoconus. Now what we are trying to assess here is when it should be implanted, would it be done in conjunction with CXL, and what to expect following such a situation. So this all started when 360-degree rings were implanted for myopia, and first it was done for keratoconus in 2000 by Collin. So what we need to remember is the diameter of the ring is inversely proportional to the dioptric correction required and the thickness directly proportional. And we do it in the posterior stroma because it is less compact. So now the mechanism of action of CXL is that it strengthens the cornea and takes care of the pathology. The rings actually make the curvatures of the cornea better and decrease the higher order aberrations. So the depth of placement also decides on what kind of stress, resultant stress happens in the cornea. So if it's the posterior stroma, that's nearly 80% of the depth, then there is prevention of ectasia progression. So anteriorly, there is actually increment of stress. So that is where the depth is important. Now the mechanism of action, the favorable ones are space creation between the corneal lamellae. There's shortening of the arc length, so it's that's why Dr. Rajesh talked about a negative meniscus and a larger diameter organic cornea to be placed for additive therapy as well, because it shortens the central arc and flattens the cornea. There's change of the disease course because of this flattening and the subsequent response of the cornea, and a decrease of the higher order comma aberrations that are commonly seen in keratoconus. Now all these are the indications of which I'll basically be talking about keratoconus. In keratoconus, now what are the indications that may let us use an ICRS? So the K value should be more than 46 diopters. You need a central, clear and non-scarred cornea with a corrected distance visual acuity of less than 6/9 parts and loss of lines due to keratoconus. The corneal pachymetry at the site of implantation of the ring should not be less than 400 microns, 450 microns for safety's sake. And then the alignment of the refractive and keratometric axis between 0 and 15 is considered to be proper, and those cases respond best. Now contraindications, like I mentioned earlier, scars, dystrophies and pregnancy, erosions, drug intake. Should be cautious in large pupils, eye rubbing and low endothelial cell counts for obvious reasons. So these are the types of ring segments that are available: the Intacs from Edition Technology, the Ferrara rings, the Kera rings, Mayo ring. So I'll be discussing basically Kera rings and Intacs because these are the ones that are commonly used. So now this is how a Ferrara ring is inserted using a keratome. So this is a mechanical form of insertion which is rarely done now. So now this is actually a very complicated technique, and it involves using this particular type of keratome that creates the pocket in a circular fashion. So with the femtosecond laser, this is actually not required. So what we do now Now this is another instance of myoring insertion. So you can see it's a total 360-degree ring, and
The
if you have
pocket
a
was
lot
created
of central
before with the
steepening,
Pocket
then
Maker
it helps in
microkeratome at 300
reducing
microns depth.
the steepness
The
of
diameter
central
of the
cornea.
pocket is
Because
9 millimeters.
when you're talking of intacts, you're talking about arcs. Now, femtosecond, can you give me a whole screen for my video here so that I can, forward it if I want to? Yeah, so for femto intacts, basically you create 2 pockets on either sides and an incision at the center. So that is the applanation. You can see that the incision happens very fast in just a couple of milliseconds following the applanation, and then this incision, the stromal pockets, they need to be incised a bit at the beginning, followed by passage of the rings. So here you can see that the incision with a central large pocket is there. That is where you make the first incisions to pass this instrument there. So this will expand the incision and give a leading a pocket for the leading edge of the ring to be passed. So now you also have asymmetric rings, with different thicknesses at different end and different diameters and different kind of shapes at different ends. So such asymmetric rings are also available that produce a separate kind of flattening in one pole compared to the other. So once the rings are passed inside, they are tugged neatly, and then this central pocket is sutured. So that was the basic method of doing the procedure. Now there are different types of cones that we can deal with. So if you have a central myopic cone, then symmetric segments may be preferred, or a 360-degree myo-ring kind of a segment may be preferred. If you have a high amount of astigmatism or a snowman kind of configuration, then you can have one on either sides. They can be symmetric or asymmetric depending on the type of cone's symmetry. If you have highly oval cones, or which are more confined to one quadrant or one side of the cornea, then you can go in for single inferior segments. So the mid-peripheral pachy is not very important in such situations. You can see that this is less than 400 over here, but still you can implant a ring because the peripheral pachy is more than the area where the ring needs to be implanted is more than 500. Now the outcomes are excellent actually, because there is a huge change in the keratometric values, and the visual acuity improves drastically. The sphere reduces drastically. So these are the anterior segment OCT pictures. Now when you want more corneal flattening, you need symmetrical implantation with greater ring thicknesses, narrow channels, and more astigmatism reduction when you have incisions on the steepest meridian and you insert the rings on the flattest ones. So these are the various combinations that you can use with intacts. And we have always found, there are multiple studies, this is one of the latest ones which highlights the benefits of CXL along with ICRS, and they have found a significant increase in visual acuity, decrease in steep K, and decrease of the mean cylinder value in these eyes. And so the benefit mechanism is that there is a traction effect of the ring at the end points on the astigmatic axis along with strengthening of the cornea. Now the question is, which comes first? So again, there are multiple studies. Now this is one of the earlier ones which found no difference whether you're doing CXL first or whether you're doing ICRS first. But then later studies have slowly proven, this is one of the later ones which had proven that CXL after ICRS implantation, not very late, but maybe along with it, is a much better technique. So now this is the total, this is I think the most important slide in this presentation, which is the total, sum total of all the studies that have been conducted, combining, I'll just take half a minute. ICRS and CXL performed simultaneously or sequentially has a synergistic benefit. And if it is performed before ICRS, it stiffens the cornea and makes the pocket creation a bit harder so that you cannot pass the rings as easily as you would otherwise. On the other hand, if you do a ring implantation and clear the central cornea and do an accelerated CXL in the same sitting, it provides much better benefits and much safer treatment also. So this is the summary of what I presented before. Then of course you have some of the complications which are actually less than 5%. One of the important ones being extrusion of the ring, epithelial ingrowth, and rarely penetration of the anterior chamber. The studies we talked about these, there can be some innocuous white deposits at the Kera ring, terminals, which are basically fatty acids. Ring extrusion is a problem, but even that is less than 5%, especially if it's implanted at the proper depth. It needs to be removed in such cases. Neovascularization may happen, especially for larger diameter rings. So this is what the histopathology of the cornea shows. There are inflammatory cells at the site of ring implantation, attenuated corneal endothelial cells, hypocellular collagen scar at the inner edge, and macrophages. So basically there's some sort of an inflammatory reaction, little bit of compromise of endothelium. Now the longest follow-up was for 68 eyes, that was in 24, and it has shown that it gives very good results, but sometimes over a large period of 10 years, the results may taper off. Thank you very much.
Thank you, Dr. Sapna. It was a very nice coverage of the topic. Can I request Dr. Anand to please come up, and meanwhile we can have any question for Dr. Sapna? Yeah.
I haven't. Yeah. Because
Because there were two index and they started touching each other, and that increases the effect if it touches the So I went to manipulate. Unfortunately, the proper instrument was not there. There was a little tilt in the index. I'm talking about the older time that we used to get those hexagonal segments. So that sharp segment it eroded inferiorly because of thin cornea and over a period of time. So I had to actually move that and we put a leveler patch after the would work with.
We had one case referred by someone who had infection, developed very severe infection. So in that case, we had to remove it, and first we, the track was drained and with antibiotic and all that. But the infection was quite severe. It progressed, and finally we had to do a therapeutic graft. So that is something, I mean, rare. That is extremely rare. But yes, that can happen rarely, very rarely.
I think it's a femtosecond laser that is the greatest advantage, because you can accurately calculate the depth and there's no penetration or extrusion.
Just a couple of points to Sapna's lovely presentation. I think one is, I think the depth is probably the most critical part. If you're, rather than calculating from the anterior, I calculate from the posterior. So if you have 20% behind, about 120 microns behind the intact is probably more important. And the second part was in terms of follow-up. I feel if you manage the allergy aggressively with traclomas and topical cyclosporin, you just have to tell them to avoid. Any experience with the allergenic implants?
Cares?
Yeah. Anybody? Rajesh?
No, I haven't done it.
Yeah, no, we have done about 4, so I have a 2-year follow-up, but I find that, and I've seen patients from other hospitals who have come to me for follow-up. I think the challenge is the predictability. I feel that nomogram, because it's a soft tissue, you don't know how much is going to correct, and the thickness is quite standard. So I think it's still in evolution.
Time, I'm sure it shrinks.
It's
There's a damping effect because there's a compaction of that.
Yeah.
Yeah.
So it kind of just dampens over.
All right. You'll have to excuse my voice. I'm sounding like Amitabh Bachchan because of my laryngitis. But just be. All right. So I thank you, Rajesh, for allowing me to be a part, and I'll touch upon some experience of what we have done with combined procedures as well. I guess when you're looking at keratoconus, the picture on the left and the right is similar. You need to stop the progression, stabilize the bulge. You need to improve the contour through intervention, and you need to have measurable results. And just for the record, that is not me. All right, I'll start with one patient, a 43-year-old gentleman who had cataract surgery, and like on most cataract surgeons, they will refer back to you saying, your vision ठीक नहीं है, थोड़ा check करके भेजो. So the surgery was done perfectly, but the cataract referring surgeon had probably missed the LASIK flap, and if you had, then I realized that the patient had actually had bilateral LASIK, and patient was suffering from ectasia, was operated for cataract, and this was the pre-op for the right and the left eyes. So both the eyes had post-LASIK ectasia, And at that time we were suggesting CXL with Intacs. That was the plan. So we went ahead with collagen cross-linking because that was the conventional wisdom. So you cross-link and then you try and touch the cornea. And he was lost to follow-up, came back in 2013, and you can see now that the ectasia is actually increased, and you got almost 11 diopter change across the pupil, which would give a lot of polyopia, and that was the challenge. So we basically planned for a topo-guided PRK at that time. This was the pre-op, and you could make out that it is reasonably central, and this was the planning that this is on the wave light, no financial interest, but you need to have measurable readings of the topography if you're trying to attempt this, and that repeatability is the most probably critical part. You also have to make sure that the refraction matches the topography. More than 15 degrees, you will have a challenge. Now, this is an important part about how the ablation is structured. So you see the ectasia where there is going to be slightly more ablation on the cornea, and if you look carefully, there is also an ablation in the mid periphery, which is to take care of the additional myopia. So you flatten the central part, you steepen the periphery. So it's, if you're looking from outside, you have a mountain and you have a plane. You flatten the mountain and steepen the plane is how it is done. And you also have something called C12 compensation for this induced hyperopia that you get. And once you do that, you basically can convert a cornea which is very eccentric with a very irregular cone into something which can be corrected with a pair of glasses. He has reasonable vision with a pair of glasses. This is pre and post-op. Similarly for the left eye, very, very irregular, very eccentric, very difficult to connect with glasses, and you can actually improve, and a lot of time they do okay with a pair of glasses. If you really want to get perfect vision, then definitely a lens, preferably a scleral lens would be preferred. And on follow-up, you can say that it maintains that flattening. You look at the Hoya eye trace, this is the right and the left eye, you can make out there is an improvement in the stimulated E, and patient does notice a reduction in halos. When you look at interventions for keratoconus, you have something in the front, you have something on, you have something in, and you have something beyond. So in keratoconus management, this is a very, very simple way of looking at how you want to treat keratoconus. And this is my broad guideline of how I look at early and advanced keratoconus, and probably an important part which Swapna touched upon was the central scarring part. Now, when you have, where does TPRK fit in is probably for early to moderate. You're very unlikely to do this for advanced keratoconus. You will probably look at a pure collagen cross-linking. So if you have a early to moderate, you can consider using TPRK in some of these patients. If you have irregular astigmatism, you can do Intacs, still add in PRK if you want. In advanced, you're probably looking at DALC with central scarring. So this is what my braid outcome. And CXL PRK is a combination treatment. So you got an upper limit of 50 microns, and the aim is not to give the perfect vision. You are just doing basically a smoothening of the steeper parts of the cornea. The principle is basically you image tomography, topography, and wavefront aberrometry. The TPRK flattens the imperfections and tends to treat only the hyoid aberrations. You're not going to get a very significant refractive correction. And it improves the central corneal asymmetry from what I showed you in a couple of the cases. And there are good number of reports on the Cretan protocol and the Athens protocol, two different authors. The concepts are slightly different, but before we go ahead, I want to tell you where Athens and Crete is, because I didn't know when I was reading the literature. They are actually both part of Greece, the upper and the lower part. Athens is the capital. Now, what is the difference between Cretan and Athens is basically in the corneal reshaping method in the Cretan and Athens is slightly different. You have topography guided PRK in the Cretan, and you have a PTK concept in the Athens. There is a partial correction of refractive errors based on topography. Athens basically regularizes the corneal surface. Both you can use manual or transepithelial can be done, and you can combine both accelerated or standard. Now you do the PRK, you treat maximum 70% of the sphere and cylinder. You got a limit of 50 to 70 microns. It is suitable only for early keratoconus. And there are multiple published studies of simultaneous PRK with collagen cross-linking. Most of them have early follow-ups up to 16 months, and they do show an improvement. An important factor in all this is the epithelial thickness. And we do know with multiple studies that there is a reduction of the epithelium over the keratoconus, and it's thicker at the base of the keratoconus. So when you're actually doing the ablation, you have to be aware of that, that you may be knocking off some of the stroma before you remove all the epithelium. The intended ablation is always going to be a maximum of 50 microns. Remember that this is after the epithelium is removed. The advantage with PTK is it does a uniform ablation. So it removes all the epithelium. You can actually track the amount of epithelium if you have an ASOCT. Most of the anti-segment OCTs now carry that. In terms of a single combined procedure, the advantage is you don't need to space it out. And there is one which was shared by Rohit. I call it the Bengaluru protocol, where you have a central cone and you have a hyperprolate cornea. That approach is slightly different, where you're working with Q, not with so central cone, where you have a more steeple part, the approach is slightly different. In eccentric cones, you got a slightly different approach, but broadly you're looking at different ablation patterns which the machine will help, but the refraction is the bottom line. Then I decided, why can't we have a Chennai protocol as well? And what I do is slightly different from what is that you are looking at a range of 47 to 55. You need 450 microns, and you can combine a standard PRK or a PTK with either of them. The intacs can be done prior to TPRK, usually about 6 months. So eligibility criteria is broadly these, no other than what I have mentioned, inflammation and no central scarring. Okay, I'll just touch upon this. This is just to mention the newer protocols with PRK called TREC, wherein the ablation is slightly different. This is one patient in one eye, which we did something called TREC, where there is focus of only the area where the cylinder is and the eccentricity is. So on the Cirrus machine, you measure the eccentric part and you ablate. Remember that TPRK is a 7 millimeter zone. Here you can bring down the zone to 3 millimeters and ablate only the cone, not around. And then you follow it up with a standard. So there is a bit of calculation required in the interface. This is on the Schwinn machine, no financial interest. But the limit is about 20 microns. So the ablation is over the cone. And you can convert an eccentric cone like this into a more regular cone. And if you combine with collagen cross-linking, you get an additional couple of diopters of correction. This is also one other eccentric cone. Post-treatment, you can almost see about 6 to 7 central reduction of K. And this is a good option. I guess this is just my last slide of where it actually fits in. You are looking at an early cone with progressive keratoconus. You can have both irregular and regular, and you can do it for both. This is some of our results. Reduction is about a lot more lesser, about 2 diopters if you do it, because you're not ablating a lot. And most of them have an improvement and stabilization of the cone. I guess future is AI with customization. To conclude, there is a reduction of higher order aberrations. There's a reduction in K up to 4 diopters if you have enough stroma. ASOCT is essential. And you're probably looking at a simultaneous. Future is probably personalized and data driven. Thank you so much.
Thank you, Dr. Anand. I would now request Dr. Namrata Sharma to present on anterior lamellar keratoplasty, big bubble or layer by layer. Any question for Dr. Anand?
So I think this is a very pertinent question, big bubble or layer by layer DALC in cases of keratoconus. So when I was beginning to learn DALC, it was layer by layer, because that is what we were taught when we were doing manual lamellar keratoplasty. And then as you become more experienced, then you start making big bubbles. And to practice big bubbles, first we used to do in cases like pseudophakic bullous keratopathy, because you know that eventually, I mean, especially which are full thickness scarring is there, you know eventually you are anyway going to do a full thickness PKP for them. So that is how you learn it. But as you become more and more well versed with the various, well versed with a particular technique, So now if I have to start any case of DALC, not only in keratoconus but any other pathology, in keratoconus, I would always do a big bubble first, and then accordingly take a call on what has to be done. But having said this, you can do either of the techniques, and as far as the visual results are concerned, provided that you have about 80 microns of these residual bed thickness, the results, the outcomes, visual outcomes actually don't matter. So there are no financial or proprietary interests, and we all know that the big bubble is the gold standard, but it is also a technique which is challenging. And Melise has described a technique which is layer by layer Melise technique. In fact, not layer by layer, but classical Melise technique, where basically air bubble is instilled in the anterior chamber, 400 microns groove is made, lamellar dissection is done, then viscoelastic is injected. The incision is then sutured, and then subsequently after suturing the incision, the trephination is done over the and this is then removed. The overlying stromal layers are then removed, followed subsequently by the placement of the donor cornea. So you don't reach up to the Descemet's membrane level, but you reach near Descemet's membrane level. Now, ever since Dua's layer came into being, we started understanding the big bubbles much better. So you have Dua's layer, which is as shown in green, but if it is above, you get a big bubble above Dua's layer, it is type 1 big bubble. And because Dua's layer is there, so it is rough, the surface is rough, but if it is below Dua's layer, then the surface is quite smooth. This is a technique to show type 1 big bubble DALC, where 60 to 70% trephination has already been done, and then subsequently air is being injected into the supradescemet's membrane compartment, and as a nick is given in the overlying stromal layers, you can see that the Descemet's membrane is coming up as the air is being egressed from here out. Again, you have to reinforce the supradescemet's membrane compartment by pushing the viscoelastic into the interface, and then like a kangaroo's pouch, this will kind of fall back, and then the excision of the overlying stromal layers can be done on this. Now, if the big bubble does form, then this technique appears to be very simple, but there can be a problem when the big bubble doesn't form. And following, of course, the exposure of the Descemet's membrane, full thickness donor cornea from which Descemet's membrane has been removed is sutured onto the host. Now, this is type 2 big bubble, and the type 2 big bubble basically you can see that it has gone right up to the periphery. This is the edge of the bubble which can be seen. It has a more glassy appearance, and the way the two bubbles behave is also different. So here actually I have not let it go beyond this keratectomy site, because if you let it go beyond the keratectomy site and then try to release the pressure, then you can perforate the Descemet's membrane. But as the paracentesis is done, notice how this bubble is also expanding inside, and then suddenly the bubbles egress out. So actually there was not one bubble, but there were two bubbles, and both of them egressed out when we do the stromal dissection. Again, the technique remains the same, that you get the Descemet's membrane to actually fall back with the use of the viscoelastic agent, and then do the excision. So these are some of the results of DALC in cases of keratoconus. Now the problem with the big bubble technique can be that there can be perforation. Now here already big bubble had formed, so the perforation occurred while excising the stromal layers. The trick over there is that you leave a little bit of stromal tissue here. It doesn't matter, it is right in the periphery, just to seal the perforation which is present. Now, in cases of healed hydrops, I don't try to do a big bubble at all, because you know that there is a breach which is there, which has scarred. Although there are surgeons who do partial big bubbles even in these cases. So trephination is done first, and then layer by layer dissection is done. And because you have intraopposite microscope, then you can actually see that you are at the area of the healed hydrops, and slightly go more anteriorly, so that you don't you don't open up the tear which was there earlier and has now scarred. So you can see a little bump here, but this bump is paracentral, and subsequently the graft is sutured. So you have a post-op picture like this, and like I said earlier, if the residual bed thickness is 80 microns or less, it actually doesn't matter, and if the visual axis is clear, it actually doesn't matter in terms of the visual results, although theoretically people will say that the results are optimized. So here it was about 52 microns. So layer by layer lamellar dissection is generally used when the big bubble cannot be achieved, and it does have lower risk of desmet rupture. It is useful in scarred corneas, and it allows controlled dissection. Only the limitation is the residual stromal interface, the possible interface, and like I said, it is said that the visual outcomes may be suboptimal, but as shown by the AAO paper, if it is 80 microns, it really doesn't matter. Then this is a technique which was described by Professor Vajpayee, the diamond blade assisted DALC, and this was basically done because when you make bubbles, there is always a fear that it may not happen. So basically what is done is pachymetry is done, and then you see what is the corneal thickness at the area where one has to trephine. Then set the diamond blade in such a manner that it goes up to 80 to 90% of the depth, and then the same plane is with the help of the vanas and the lamellar dissectors, it is dissected and then sutured with 10-0 monofilament nylon sutures. So like I said earlier, it really doesn't matter, especially if the scar is paracentral. Now again, in cases of keratoglobus or very large keratoconus, you would not try to do big bubble like this. In those cases, tuck-in lamellar keratoplasty is a better technique. I'm not showing the video of this technique because I think this video is of keratoglobus. But if you have a large keratoconus or you have a keratoconus with pellucid marginal degeneration, then this can be done. Such as this was a case of keratoconus with pellucid marginal degeneration. So there's a peripheral flange which has been fashioned, and this flange is tucked inside the pocket that was created, and a tuck-in lamellar keratoplasty is done here. Dissection is again layer by layer, and here again when you have peripheral thinning, then it is difficult to again do big bubble. So this is the same case where half tilk was done, and then cataract was there, and then cataract surgery also was done. So I think the surgical strategy in keratoconus should be that you should, if you are not comfortable with big bubble, then you go layer by layer. It does not matter. But if you want to attempt a big bubble, then one can always attempt a big bubble, and if the bubble fails, then go in for layer by layer dissection. If the desmet membrane ruptures, then again either layer by layer dissection can be done despite a perforation, if the perforation is small, or convert to a PKP. Bare desmet talc is a ideal goal, but it is not mandatory, like I said earlier. And layer by layer is a essential fallback technique, and both the techniques, however, are critical skills in corneal surgery. So for beginners, layer by layer. As you become more experienced with that, big bubble can be done, and of course healed hydrops again, I'll say layer by layer. So thank you very much for your kind attention.
Thank you, ma'am, and it was a very nice presentation, very nicely covered each and everything. Next speaker is Dr. Varsha Rathi. Meanwhile, any question for Dr. Namrata? The next speaker is Dr. Varsha Rathi, who will be talking about contact lens designs for keratoconus, corneal and miniscleral.
How many of you practice contact lenses along with all the surgeries what have been shown? How many of you practice contact lenses? Have set up in your clinic? Yeah, I know you all would have the people. Yeah, okay. So this is to take you through the various contact lenses options what we have. So this is about the various contact lens designs what we have. And I would be using terms like mild, moderate, advanced, severe, and the type of cone what we have, nipple, oval, and globus cones.
Can you get the mic closer? Yeah.
Okay. Yeah. I can't see the slides here, that's it. So he's doing from there. Arrow is, I cannot see the arrow. Okay. Slideshow करो.
And 2 were supposed to come, and now we have only 68 because all flights have been disrupted because of this.
Yeah. So to continue, we have the variety of cones. Every one of us knows about the type of cones which corneal topography will help us understand. A variety of options, what we have heard today, you can practice. But then the basic, we would start with spectacles and contact lenses. The challenges for a contact lens practitioner are to provide good vision with comfort for these patients and to have follow-up of these patients so that you can plan surgery in future if required. A variety of contact lens options are available, such as soft RGP, piggyback, which is a RGP over a soft contact lens, hybrid lens, which is RGP with a scleral skirt, semi-scleral and scleral contact lenses. Soft torics have limited use. You can use it in early stages or if a patient is unable to use the RGP lens. But the other lenses are customized to soft toric contact lenses. A variety of lenses are available. You don't have to use all. You can just stick to say 1 or 2, or you can use 1. Like we use Kerasoft lenses, which are silicone hydrogel lenses. You can correct up to -15 diopter cylinder with these lenses. And there is a marking at 6 o'clock, which you can see in the picture, and you can see that the fitting should be stable. If the cone, this increases astigmatism, you can still continue using that. None of us would like to see an RGP over eye which has got an edge lift. What we would like to see is a very well-fitting contact lens over the eye. So there are 3 fitting philosophies, and you have to assess every RGP with fluorescein. So there are 3 fitting philosophies: apical clearance, apical bearing, and 3-point touch. As you can see in apical clearance, there will be a lot of fluorescein in the center, but the astigmatism which this fit would correct would be lesser because there is a gap between the lens and the corneal surface. Apical bearing, as you can see from the picture, there is a darker area of fluorescein. That means the lens is pressing on the eye. This will give very good vision to the patient, but over time, patient may become intolerant, corneal scars will develop, and whatever surgeries we have heard today, you can do those surgeries. The most ideal fitting would be 3-point touch, that will give divided support, as you can see here, and this should be your preferred lens fitting method. So a variety of things we would need to know from corneal topography, that is cone location, cone size, amount of astigmatism, myopia which the patient has, and if the disease is progressing. For the initial lens selection, we would need to know the power. For early cone, we can start with low power lenses, and then later on we can use the high minus lenses. Keratometry or topography will help us understand the base curve. Diameter of the lens is dependent on the cone of the keratoconus, and the other curves we can select. So usually we would prefer for smaller diameter lens for smaller and central cones, and for larger diameter lenses would be selected for larger and decentered cones, because sometimes a cone would be inferior. Initially you can start with mean K values, and then based on the other parameters you may have to change. This is the ideal, I would say, light touch in the center. Probably I'm more focusing most of the time on this lens fit, so that you would remember this and you can have this in your practice. Every fitting we assess static and dynamic, that is with movement. So static, if you can see, there would be excessive central clearance if it's a tight fitting, because the lens won't move much on the surface. A loose fitting lens will have darker areas, it will move more, and the movements would be more than 2 millimeters. So this you should not ask for, but sometimes if the fit is acceptable, patient is comfortable, you can use this. This is the ideal one. I would say there is a minimal center clearance, light mid peripheral touch, edge width should be optimal, and edge clearance also should be there. And these are usually either under the lid fit, or you can have a centralized fit, and movements here are between 1 to 2 millimeter. So for advanced keratoconus, you can try steeper and smaller lenses. Base curve should be equivalent to the mean K values, and you can start with the lens which gives you apical clearance, and then you can change based on how you are getting the fitting. And these are the various, I am just showing you how the lens would look in a nipple cone and oval and globus cone, where you will have to use a larger diameter lens. The most important lenses what we use are Rosquet lenses. Probably every one of you must have heard about these lenses. And as you can see, the optical zone here of the lens would be covering the cone area. So it's a very small optical zone with Rosquet lens compared to the standard lenses. This will reduce the chair time, the fit will be very good, patient will be very comfortable, and it has got now some advanced fitting options which are there. You can change the edge lift. If there is edge lift, you need to specify where is the edge lift and what you have to do. Intralimbal lenses are the larger diameter lenses which can be used, and again the fit here would be better. The lens doesn't move much. Piggyback is prescribed when the patient is intolerant to RGP, and one can use soft contact lens, and on top of that one can use RGP. The movements of these lenses are independent of each other. And then there is a flex lens, where is a soft lens which has groove, and RGP moves in that groove area of the soft contact lens. I have not used these lenses, prescribed these lenses, but I have seen these lenses initially, I would say. Because these are two lenses, we need to handle these lenses better. And hybrid lenses also one can prescribe, but nowadays with the scleral lenses what we have reduced these in the practice. So scleral contact lenses, as you can see here, it's pretty larger, as you can see, compared to RGP lens, and also in the other area, you can see that. These lenses do not touch the cornea. That is what is more important for every one of us to know. A variety of lenses are available, such as corneoscleral, semi-scleral, mini-scleral. A variety of lenses are there. You don't have to keep every lens in your practice. You can just stick to few lenses and learn from those lenses. So Jupiter scleral lenses, these are available as 15 to 18 millimeter, and they have got, I would say, 3 zones for every lens we would look into, and we have to do the fitting accordingly. The Europa scleral lens is advanced version of, I would say, Jupiter scleral lenses, as you can see here. Rose K2 XL, these are available in India. One can use these lenses, and it has got various fit options which are available. And as you can see, you can change the fitting of these lenses based on the edge, how the edge is. These are some of the photographs to show you how the central fit or ideal peripheral fit would look like. Diameter of these lenses is 1.3 to 1.5 millimeter beyond limbus. So based on the corneal diameter, you can order these lenses. And to decrease the movement or increase the movement, you have to decrease the edge lift or steepen the base curve or opposite. And scleral contact lenses, as we all know, we can prescribe in any type of keratoconus. And these were the two basic types, air ventilated and fluid ventilated. I have used fluid ventilated. I would say I have learned from Dr. Perry Rosenthal about these lenses, and we use spline technology. The lenses now we have in India in our setup, we manufacture these lenses. Haptic and vault is very crucial in this, and the lenses are like flush fitting to the cornea. You can change the vault, and I would say you can prescribe any type of keratoconus. The most important here disadvantage would be the cost of these lenses, which is on a higher side. Whether it is a Boston side scleral or the scleral contact lenses, the cost of these lenses is high. But you can use these lenses in patients having VKC or combined SJS. After, I would say, collagen cross-linking, I have prescribed the RGP lenses, and after intracorneal ring segments, we can prescribe scleral contact lenses also. This was a 79-year-old lady who had eye drops and then a scar, and she didn't want to undergo surgery. We had prescribed her lenses, and we could give her 20/80 vision. So you can give these lenses to anyone. This should be first line of management. Surgery should be indicated only, probably I would say, when the visual acuity does not improve. There are certain problems with any contact lens we can see. So in the end, I would say that these are the various lenses which are available, and probably one need to start, because I could see only 2 or 3 raised hands. Probably you can have this in your practice. Thank you very much.
Thank you, Dr. Varsha, for a very nice coverage of the topic. Thank you very much. Any question for Dr. Varsha? Meanwhile, I'll request Dr. Amit Gupta to please come up for his interesting talk on IL power calculation in eyes with keratoconus. He's the last speaker of the session.
Well, a very good morning, and thank you, Dr. Rajesh, for such a wonderful instruction course on keratoconus management. So I'll be talking about the intraocular lens power calculations and the challenges in patients of keratoconus who are undergoing cataract surgery. And you know why cataract surgery in keratoconus is challenging is because the cornea is multifocal, it's irregular, and the visual axis often lies on the slope of the cone and not the apex. And therefore the standard keratometric assumptions, they fail. And there's a high risk of post-operative hyperopia. So this sums up, you know, so many of things. Most important is the decision when to operate on these patients. Which component of the decrease in vision is due to cataract and which is due to keratoconus. So sometimes that can be a challenge. Which intraocular lens calculation formula to use, that itself is a challenge. What will be the effective lens position, that can be altered. And so many, the relations of anterior chamber depth, corneal thickness, axial length, they are all changed. And many of these patients are high myope, which adds to the complications in these patients. So to sum up these K readings in keratoconus, what happens is the center is steeper and therefore the corneal power will be more in the center, and the biometry will assume this high power overall for the eye, and therefore there will be an overestimation of corneal power, and therefore there will be a hyperopic shift in these patients. Often they are left with a plus. So the steep central cone, it biases the K readings. Apexes are often not aligned, and larger cones often exaggerate corneal power, and more significant when the keratometry of this patient is more than 55 diopters. That's when we should be more careful in these patients. So what to do in these patients? So there are several publications and found this very interesting. So they use the total corneal refractive power in advanced cases. So they have advocated that in mild to moderate keratoconus, perhaps you can get away with the K reading of the patient. But however, in this, and how do you get the TCRP? You go to the pentacam, you go to the cataract preoperative map and the bottom right corner, and I'll just highlight that for you. So what they've advocated is the use of total corneal refractive power at the apex. You can take it 2 or about 3 millimeters on an average at the apex. Now another publication by Watson et al., what they did was they used standard K in advanced cases of keratoconus. Standard K means 43.25 is what they have used. So again, they found in mild to moderate keratoconus, it was reasonable to use the actual K, but in cases of severe keratoconus, they got better results and less of hyperopia because there was a myopic shift in the outcome of these patients. So one, we are sorting out what kind of keratometry to use. Second, which IOL formula to use. So we have so many of these IOL formulas, and again several publications have shown then that SRKT amongst the traditional IOL formulas, it performs the best and has the lowest error. And this has been again also shown in another publication in JCRS. So while most formulas they led to hyperopic refractive outcome, the SRKT was the most accurate formula out of these. But do we have something better than that? So we have now the Kane formula and the Kane keratoconus modification of the Kane formula. So this was a very important publication, and this compared various IOL formula with the Kane IOL formula. So this is available on iolformula.com. You don't have to buy it. So it uses a modified corneal power. It minimizes the K-dependent ELP error. It improves the accuracy across several severities, and it's the preferred modern formulas. What Kane has done is he's divided the keratoconus less than 48 diopters and more than 48 and 53, more than 53, and recommended that the target refraction be set as no adjustment in stage 2, 0.75 to minus 1.5, and stage 3 minus 2 to minus 3. Of course, it is dependent on the surgeon what you choose ultimately. Better to go towards a myopic bias to avoid a hyperopia. So this is it takes into account axial length, keratometry, antechamber depth, lens thickness, central corneal thickness, gender of the patient. And now it's been shown that Kane, even for normal eyes, is almost the most accurate formula. And this summing up some of the results, if you see the mean prediction errors and the mean absolute prediction errors, they were the least with the Kane keratoconus formula in these eyes. A word about the toric IOLs in these patients. usually done for mild to moderate keratoconus and non-progressive disease, and patients that were not dependent on RGP lens for achieving a good visual acuity, and a good history of spectacle corrected visual acuity, which is better than 20/40, not high irregular astigmatism in the central 4 millimeter of cornea. This is a very difficult call for the surgeon to take. Many times we go in favor of a monofocal non-toric IOL than a toric IOL if we know that after surgery the spectacle corrected visual acuity can be good. So just summing up on the decision tree, we have mild keratoconus, we can go with actual readings using probably the SRKT or Kane formula, moderate keratoconus, and then advanced keratoconus as I've summed up. Either use a 43.25 or we use a TCRP. Take home messages, always identify the source of visual loss. Is it really the cornea? Because if it's the cornea and not too much of cataract, the patient may not be happy with it. He will end up with a presbyopic correction, and that will further add to his miseries. And keratometry is the weakest link. Spend time on keratometry, maybe recheck with different instruments what kind of you want to do, but pentacam is of course the mainstay. Avoid using using actual K in advanced keratoconus. I have told you the modifications. Kane formula is very good, improves the predictability, and always counsel the patients about the refractive uncertainty in these patients. Thank you very much.
Thank you.
In case of mild, by mild, what we are talking about is less than 48 keratometry. You can go with the actual K reading, even on a IOL Master 700, right? And maybe you will go in for a Kane formula still, or you can go in with the Barrett's, or you can go for the SRKT. You can have all of them, see if there's not too much of variation. In case of moderate keratoconus, which is 48 to 55 diopters of keratometry, what you would probably do is again take a call in more severe cases, see the variations. But I would nowadays we are going with Kane keratoconus formula in these patients, right? And you can use an actual keratometry of the patient, but definitely and go for the target refraction, which is targeting at least minus 1.5 to minus 2. Target refraction very important that you feed. But if in cases more than 55, and I have done now many cases using a TCRP, and also I have done using 43.25, our results are very good. In the interest of time, I didn't present those cases. They were actually very good, and so we didn't have much of hyperopia, just borderline, almost they were emetropic. So that was big achievement in severe eyes.
One last question: the refractive index changes after CXL. If we have done the CXL, so how do we go ahead? Like these formulas are for the normal refractive index. Like
Yeah.
The Barrett True K with TK. Using TK
Yeah.
from the IOL master, if you use the Barrett True K for KCN, it gives very, very good and very, very less residual refractive errors post CXL.
Okay.
There's a true KTK modification on this thing. Yeah.
Yeah, that's true. And maybe you can use two instruments to cross check. That is what we have seen. And if you, in a case of, in all these cases, it's always better to use two instruments to cross check. Yes, Schimflug imaging is always preferable when you are taking keratometry for keratoconus.
I do take a look at the EKR map.
Yeah.
It stacks up. It's a weighted mean. It means it gives more weight to the central K readings than to the peripheral. So if you see a weighted mean at 4.5 millimeters, it again leads you to which K you should feed.
Okay. Thank you very much. Actually, we have crossed our time, and my sincere apologies to Dr. Arup and his team for waiting. But unfortunately, we also received it after 12-13 minutes. So very sorry for that. But